Getting around is important to a healthy lifestyle. Staying mobile as we age. Tonight, On Call with the Prairie Doc.
Hello, welcome to On Call with the Prairie Doc. Tonight we discuss how to stay moving as we age. We'll discuss issues like the pain of arthritis may hinder your movement, or how falls are a danger to the elderly, or how to treat pain with non-medicinal means, or how to keep your strength and balance through the aging process, and more. Joining us is Dr. Chris Diedrich, who is a physical medicine and rehabilitation doctor at Rehab Doctors in Rapid City. And also with us is Dr. Jennifer May, a rheumatologist with Regional Health here in Rapid City. Welcome, both of you. So people always ask me, what is a physical medicine rehab doctor? Chris, could you explain that?
We primarily wear lots of hats. We do a variety of things: non-operative musculoskeletal medicine, neck pain, back pain, shoulders, hips, knees. We basically manage individuals from their initial injury all the way to getting back to work or back to recreational activities and maybe their sport.
How about after surgery? I mean, are you the guy who helps get a guy who's just had his knee replaced, for example?
Often we work with individuals, we work with the physical therapist. It's a team approach. It's working on getting somebody from their surgery or their injury all the way back to whether it's their job or their sport or working out, whatever their activity is.
The word is function, isn't it? Getting people to function.
Absolutely.
And a rheumatologist, I mean, kind of similar in some sense, you know, working with movement, joints and so on and so forth. What got you into that, Jennifer?
I rotated in medical school with rheumatologists and found it interesting. And I think the thing that I really liked about it was when you understand the underlying disease process, you can affect a treatment that can make somebody who's maybe suffering and having a lot of problems become minimally symptomatic or very functional when we kind of get the right medicine for the right problem.
I like the idea of, there it is, the word function again, getting back to function. So one of the things that I love to encourage people to do so that they can keep function is to move. I mean, to keep moving. We are even doing a research project right now called 4Me, 4 M's, make muscles move more, and then eat correctly. So we've got 4Me is our name. And I encourage people to keep moving. But the worry I always have is I'm encouraging all this walking, right? Somebody's at higher risk of falling. And it's in the elderly that we're trying to push this walking. So there's that fine balance of get them moving, but let's not hurt them. Any words?
Well, initially, that's the challenge, is how do you get somebody moving? It's kind of like trying to get a big boulder to start rolling a little bit. And so sometimes the phrase is start embarrassingly slow, a little bit at a time, step by step, just gradually increase what you're doing. And I think that's how we initially start the process. The form of exercise isn't necessarily that important. Find something that you like or enjoy or that's available to you. We have water-based exercise in our community. It's not available in every community. Sometimes that's an option, sometimes not. Maybe it's a recumbent bicycle where you're not putting weight through your hips and your knees or your back. Maybe it's, bicycling with your spouse because that's enjoyable. Whatever works for you, as long as you're doing something, it's better than doing nothing.
Right. I had this gentleman who said, well, gee, I was doing this exercise like you said, and it hurt. But I just kind of worked up to that hurt, maybe just a little bit past it. And then the next time I could go a little bit further, and the next time I could get further, and then now it's not hurting. I always wondered that people that have that certain amount of pain stops them from getting that exercise going. Any comment about that, Jennifer?
No, I agree with Dr. Diedrich. I tell people it's just, you got to start somewhere. So you encourage people to move. I mean, being active, use it or lose it, right? I mean, being active is a key to health. And sometimes the other barrier we overcome is people believe they're active when they're not really active.
Right.
So we have to kind of really define that this is a specific thing that you do. It's not just living. It's not just, well, I move around a lot all day. I go downstairs and get the laundry, or, it's like, no, you really actually have to dedicate time, schedule it, plan it, and work at that. And that's probably one of the harder things to kind of communicate, because it's not their habit oftentimes.
Is there a certain amount of time that you think is the amount that people should do? I mean, is it 30 minutes? Is it 10 minutes 3 times a day? Is it 2 hours? I mean, how much movement do you like to goal people at?
I think 20 minutes, 3 to 5 days a week is probably a reasonable goal. That may not be where we start. I think you may have to start less than that. Some people might only be able to be on a bike or on the treadmill for a couple minutes before they, have to stop or limit themselves. But I think you start and gradually work up to that.
One of the things that I've been saying to my group, they're 70 years to 95, and we've got 94 of them moving, and I'm thinking we're gaining a little. This is pretty neat. So one of the things that I say is I like to have you walking outside if you can, because that's a balance exercise, because it's irregular. It's not like walking on a treadmill that's exactly the same. But I don't want you falling, so I'm encouraging walking sticks. And I've said that it is not the strength in the stick so much as it gives you a sense of where you are in space. And what's your take on that?
I think walking sticks are great, and I support that as well. And in an ideal world, people would go outside and walk for 30 minutes or go up hills, go down hills. They'd be able to do that. But for safety, lots of times I tell them to walk inside, particularly in the winter around here, whether it's the mall or someplace. But, whatever they can do to feel as safe as they can be. I often refer people to physical therapy for balance assessment and gait evaluation to show them safe ways to exercise and really address some of those balance issues so that they don't get ambitious, decide to go exercise, and then overdo it. And
then they overdo it.
Yeah.
And then it hurts and they won't do it anymore.
And that's what we often see is someone makes a decision. The classic story is January 1st. I'm going to start exercising. I'm going to work out again. And they get into, I'm going to do 30 minutes here because that's what I think is the right thing to do. And they overdo it, and they maybe get 1 or 2 or 3 days worth of exercise, and then they're done.
Yeah, they can't.
And they're too sore, and they took 1 step forward and 3 back, and now they're not able to do it at all instead of gradually pacing themselves and working it into a normal routine.
A lot of people talk about balance exercises. It's sort of like you can't walk a tightrope in a circus or between twin towers, let's say, without practice. And there's some data to say that if you practice balancing, like pretend like you're walking a straight line for the police when they stop you because they think you've been drinking, that kind of a practice. If you practice that, you get better at it. Have you heard any of that? That's a physiatry.
We often have people stand on one leg while you're doing the dishes. And you can switch from side to side. You have a counter there for balance and for safety, but you can work on your leg balance or your leg strength. We would sometimes say while you're brushing your teeth, do that same thing.
Right. I've also heard hopping or running on the balls of your feet for a certain period of time, if you can, not overdoing it, will strengthen the bones. I sense that this may be a more important treatment for osteoporosis, really, almost than any pills. What's your take on osteoporosis and exercise?
Well, it's very important. And I would say resistance exercise is probably the most effective as far as seeing actual improvement in bone density. Certainly, any kind of stress to the bone contributes. So we will accept walking, but there's a lot of other exercises that might be more effective. Osteoporosis to me is a lot like osteoarthritis. It's not just pills. It's not just exercise. It's the whole kit and caboodle.
Kit and caboodle.
Yeah.
That's a great word. So, one condition affecting movement as we age is osteoarthritis. Here we meet a farmer who has had to deal with this over the years.
And I wanted to be active and have something, reason to get up in the morning. So that's why I wanted to see if I could tolerate the pain, and the knee I did scope last August. We had it scoped. Dr. Luby did that, and he said we're gonna eventually, probably I will have to have a new knee, but as it works for me right now, I sleep at night and I can do my work, and so as long as that lasts, I don't want to do anything major. He takes an X-ray and he looks at that, and I've got bone on bone, and there's inflammation around the kneecap and the area. When I first started farming with my father, and it was in a big hurry to get everything done. So instead of stepping down from the tractor, I jumped down and hit the ground running and go on to the next project. And of course, he said, "You're going to pay for that someday. All this jarring, just why don't you step down?" Well, I haven't got time. Well, he was right. And I think probably that had something to do with it on my knees anyway. Maybe not, but some days I can walk, 4 or 5 miles in my work. Actually, just walking to get my work done every day is 3 or 4 miles anyway. How many times you go across, back and forth across the yard, but it does count up. Dr. Luby, who operated on my knee last August, he's recommended I take a leave if I need to. I start out in the morning, and it's, I don't have too much pain, but the more I use it, the worse it gets. In my walking, there's, if you walk on the pavement, that's level, okay? And if I'm walking on ground, it's not level, it's uneven, and all of a sudden I may step on something and whoa, it really gets my attention. So when I'm walking in level ground, not a problem, but that'll flare up and then it'll hurt. If I don't do the work, it doesn't get done. So I've reduced the number of cattle that I have, but I've still got, somewhere around 60 cow-calf operation. And so if I don't do it, it doesn't get done. So I have to make sure that whether it's rain or shine or a snow blow or, a snowstorm or whatever, that livestock has to be taken care of. My goal is to just stay active as long as I possibly can. And like I told my wife, the cow herd gives me a reason to have to get up in the morning and do it. And so that's my reason for staying with it and making sure that this thing is going to last as long as I can.
Jennifer, at the end of that video, something like 80% of the people with osteoarthritis had some kind of limitation of movement. And you look at all the people who have osteoarthritis, I bet it's 30% or more people who are over 70 that have, therefore, limitation of movement. How do you help people past that, or why is it that they're limited?
Well, I think every patient is different as to how their osteoarthritis might affect them. So particularly if it's weight-bearing joints like knees, hips, and again, it's working together with a lot of things. So it might be bracing, physical therapy, strengthening, joint injections, topical rubs. I mean, all those things we'll use to try to, again, keep people as functional as possible. So a lot of it will just depend on how, some people you can give them some ibuprofen and tell them some strategies and they're good, and other people it takes all of that, and at the end of the day they get their joint replaced because it just all those conservative things just didn't work for them.
Just doesn't work. Mm-hmm. I often think that, for example, Jim, our farmer friend, thank you, Jim, for doing that, willing to be on camera. I think part of his problem is he's jumping off of a tractor, coming down and repeated trauma. I think of football players who end up with an osteoarthritis because of repeated trauma. But that's not the only reason people have osteoarthritis. Chris?
Well, I mean, it's a little bit of genetics. It's a little bit of lifestyle. It's previous injuries that create a ripple effect of some damage to that tissue or to the knee or the joint that then over time, kind of accumulates some of this wear and tear.
And people talk about, okay, well, I'm just going to end up with a replaced knee. Do they, bone on bone, that's quote unquote the indication, right? Does that mean you have to have a replacement? How many of these people really should go to surgery or need to have surgery?
I think you get back to the word function again. When people start to lose function or they quit being able to walk, they quit being able to be active, they can't do the things that they want to do, that's when they get into trouble.
Yeah.
The individual who stays active stays much more youthful than the person who quits everything, and we see those people decline functionally, they age more, they give up all their activities, they can't be with their friends or their family. Those are the people that are significantly affected. That's when you make that step towards a joint replacement.
So one of those articles that I read many years ago that I have repeated year after year after year, I'm going to ask you for validation, okay? And the article, the study said they took bone-on-bone arthritis patients, 100 of them, 50 of them, they left them on the couch to do whatever they want to do. And 50 of them, they forced them to walk and move and be mobile and exercise. And who do you think had less pain, more function, happier overall, everything? It was the exercisers. Now, tell me I'm been saying the truth.
Yeah, I think it's true. I think you have to be active, but there, like Dr. Dietrich was saying, there are people, I always say how the x-ray looks is not describe how you feel. There'll be people that you x-ray their joints and you think, wow, does that joint bother you? They'll say, not so much. Somebody else whose joint really doesn't look so bad will be having a lot of problems. So there's more to it than just cartilage loss. And I usually tell people also, you never have to have a joint replacement. It's always elective. So that's where the patient, you'll hear people say, oh, well, the doctor said I have to have one day.
No.
It's up to you. You will decide when it's right for you based on all those things that Dr. Dietrich just mentioned.
Right. So we almost always go to pills to treat people with pain. I mean, that's the knee-jerk reaction by the doctors, isn't it? And there's a lot said about the fact that we've gotten ourselves into trouble by pushing pills and not doing the other things. And so I would like to get into that, but one of the first questions I have is something you brought up, Jennifer. The creams, for example, the really smelly, types of ointments that people can smear on joints. What do you think? Does that really work? Do you like prescribing those kinds of things?
I offer it, and for certain, and again, everyone's different. Some people really like them and get a lot of benefit out of them. But it's kind of 50-50, I would say, for the topical anti-inflammatory creams. But you can also go to compound pharmacies and you get a mix of kind of nerve medicine, non-steroidal, a couple other things in there. And for a patient, for example, an elderly patient who maybe really is not a surgical candidate, who we've kind of exhausted a lot of conservative measures, just one more thing that we can do to at least give them something to do,
right?
To help relieve the pain. It may not be perfect, but it's better than nothing.
Yeah, let's talk about the compound pharmacy mixing things. Chris, have you prescribed a lot of that type of thing?
Yeah, I think we use a lot of different tools like that. Topicals, some compounded agents, topical patches, lidocaine or numbing patches. We sort of view this as a toolbox. You have your toolbox of how you're going to manage whatever it is that you're dealing with, whether it's your shoulder or your hip or your knee. For some people, those things work really well. Maybe we're talking about an ice pack or a heating pad or a hot tub. I mean, there's a variety of tools that you would use to manage your symptoms.
I have to say, that recently I was having some belly pain, got into the hot tub, belly pain went away. Hot tub can be a really good thing. Oh, yeah. It can be.
Especially around here when it gets cold and we get weather fronts that come through, a lot of people feel better when they warm up. We also advocate for undergarments, right? Cuddle duds or, thermal underwear that keeps you warm, keeps your core temp up in the winter. Sometimes that can make people feel better too.
So if I'm a guy and I'm having some arthritic problems and I don't like to go to the doctor, and so I like to be active. I'm a farmer, I'm really moving, I'm doing a lot, but I have some aches and pains. Are there some over-the-counter things that I can do? Pills, the non-steroidals, are they safe? Are they reasonable? What would you recommend?
Yeah, you can certainly start with over-the-counter things. So as you get older, of course, the non-steroidal medications like ibuprofen or Aleve, those types of products can irritate the kidneys, can irritate the tummy. So a lot of it depends on your underlying health issues, but assuming that you don't have any problems that would make them unsafe, you're more than welcome to take those medications as directed. In fact, or alternate it with Tylenol. That's perfectly reasonable. So I often start with over-the-counter products, and then we move to prescription anti-inflammatories if need be, and kind of work up the ladder, so to speak.
I think everything in moderation. I think where we see people get into trouble is a couple of ibuprofen maybe helped a little bit, so I'm going to take even more. And then I'm going to take even more. And well, I need to go do some chores around the house or the yard, so then I'm going to take even more. And that's when people get into trouble.
Right. You want to keep your Tylenol dose down to 3 grams or 3,000 milligrams, and if you take extra strength, that's half a milligram, so that means 6 extra strength Tylenol would be your max for a day, right? I kind of like the idea of encouraging people to use as needed, but not regular use of the non-steroidals or the Tylenols. Is that a reasonable thing?
I guess I think it depends. What I usually will recommend is that people, first you have to find out if it works. So people take stuff and they quit stuff and they start stuff and they really don't know if it helps. So I'll recommend taking something consistently for maybe 1 or 2 weeks, kind of write down, does it really make a difference? And if they're like, oh wow, it makes a tremendous difference, then they could start peeling it back and kind of, maybe I don't need to take it all the time. Maybe now that I understand what relief I'm getting and what I'm expecting, then they can kind of tailor it.
So, and we're talking doing the Tylenol or the ibuprofen. What about herbal supplements or chondroitin sulfate and those things? Where are you at with those?
Well, technically, I would say the data really shows there isn't a lot of
Science behind it.
right. But, we all have those people who take it and say it works great for them. It's a low-risk medication or supplement. And so if someone wants to try it, they're already taking it, then what I will recommend is, go ahead and take it, just the glucosamine. You don't really need the chondroitin. You can get generic, a big bottle at the store, but take it for like 3 months. Again, keep track. Does this really make a difference in how I feel? If you don't notice anything, there's really no value in taking it. If you say, wow, I take this and I feel a lot better, then I don't really have a problem with you taking it. Right. But most people will tell you after 3 months that it really didn't
make a lot
of difference. Yeah.
I've found that when I'm pushing it, it doesn't seem to work. If they've discovered it on their own, they come in, it works. So Chris, you were going to say.
And I think the biggest risk is to the pocketbook. I mean, there's things like that you can try. If it works for you, great. It's another tool in your toolbox. If it doesn't work, then I think, like Jennifer said, you eliminate this and try to simplify things as you learn and learn how to manage your problem or your symptoms.
So I have seen that people sell, particularly through TV ads, chondroitin sulfate, basically, or the glucosamine. And that's all it is, but it's really expensive because they pile on all of this. This promises to do, oh my goodness, this is the greatest thing. When you can go to the grocery store and find the chondroitin sulfate that's very cheap. Do you see that as a real deal or what's happening?
None of these supplements are regulated by the FDA. So we really have very limited knowledge about what percentage of that material is in each dose, and from bottle to bottle, is it the same product? And so just because it costs more doesn't necessarily mean it's better or more regulated. I think, find a reputable brand, a reputable product that works for you, and that's reasonable. Cost doesn't necessarily equate to a better product.
Right. So we're talking about all these alternative therapies. One of the alternative therapies is Tai Chi. Another alternative therapy is acupuncture. There's a variety of different alternative therapies. What's your take on those, Jen?
Tai Chi has some scientific validity as far as improving pain in certain knee osteoarthritis patients. I think it's another tool. If that's an exercise you're willing to do. I think it's great.
And what is it? Really, is it kind of slow movement,
kind of
balancing stuff?
Right. And it's kind of I'm not super familiar with it beyond, just that kind of it's not really isometric, but it's almost kind of isometric exercise, stabilization, controlled movements. But it contributes to, I think, that sense of balance and stability that builds strength.
You're using muscle groups. You're contracting muscles. You're making muscles work without having to go through huge ranges of motion. You're not doing squats and jumps, and you're not lifting up overhead or having to use a lot of weight. It's using your own body. It kind of is similar, maybe a different philosophy than Pilates, but the same idea is that you're using your body weight to build up muscles around joints. Kind of our best brace that we have is to be strong around a joint.
Right, better than any mechanical brace.
Right.
I often thought that mechanical braces just make the muscles that were there weaker. I mean, I think there's a place for braces, but I'm reluctant to use them.
It can make things weaker. I think sometimes there's a little bit of a proprioceptive or a sensation feeling of I have something around my knee. I'm going to be a little bit more careful about how I'm stepping or how I'm walking with my knee. Maybe it controls swelling a little bit. A lot of these braces are that neoprene or that elastic. They kind of keep the swelling and some of that down. But again, the best brace is always your muscles around the joint. That's the way we were designed.
Yeah. What about acupuncture? We didn't touch on that. Do you think it's a real deal, or is it? There's some people really believe in it.
There's two philosophies: the Eastern Asian aligning of meridians and your chi, and very hard to study, very philosophical, very holistic, tough to study per our traditional medical model and our medical research. It does release endorphins, kind of our body's natural pain relievers, and some of those chemicals, and so there's probably something to that, probably something to maybe releasing some tight muscles or some trigger points. It's a tool. It can be helpful for some folks. Some people really find benefit from it.
Pressure point. I have used a number of, for many years, probably not in the last 10, but before that, I used pressure point techniques. I'd find the trigger point, and if I didn't inject a little Novocaine, I would put my thumb pressure on it, or encourage people to use a doorknob and wait 8 seconds and put pressure on that point and see if they can get it to come out of spasm. Any belief in that? I mean, is that similar, or what do you guys think?
All those stretches, things at home, we use foam rollers, towel stretches, things for tight muscles or muscle groups like that, common therapy techniques. If the doorknob doesn't work, you can lay on a tennis ball or a racket ball.
Find that trigger point and put a little pressure on it.
Kind of a massage. It's a touch through that area that's a little tender to kind of try to break that up. Typically, those tender points or those trigger points are your body saying there's something else going on underneath, right? There's a sore joint, there's a sore rib, and then your body kind of spasms down to guard or protect you and say, hey, quit moving this way, this is hurting.
Yeah, good. Support hose are very important in the treatment of swelling and venous problems in the legs. Getting the darn things on can be frustrating for some, but an exercise to limber hands and arms and an opportunity for success for others. Here's one man's story.
I had a sore on my ankle, right at the ankle bone. They called it an ulcer. Anyway, it got to be just like a hole the size of my fingernail, and it just wouldn't heal. Well, finally, Dr. Holm, after probably a couple of years, said, let's try support hose. So we started with support hose. It took a while, probably 2-3 months, but all of a sudden it started healing up. And I haven't had any trouble since, but once in a while I feel like it's a little bit tender there yet. Then I got varicose veins. That's another reason that I wear these. And it's so comforting. Before I had the restaurant, I was on my feet probably 16 hours a day. And my calf would get so sore and tender and ache. So I started wearing them, and that didn't cure the varicose veins, but it sure helped the pain. Yeah. So, and the left foot, the left leg, that's not any problems. So it's the right leg that I've got wear the support hose for. Take your left hand down and your right hand to the side and bring that as far as you can up to towards your toes. Then you take your thumb, get your 3 fingers down, bring it over the heel, and your sock is resting on the floor.
I'm a big believer in wearing compression stockings. And you know, I push it and push it because it's one reason why people have swelling in their legs, and one treatment without using diuretics, without adding pills, that you can help people, particularly with venous problems. And I know it's a little bit separate from osteoarthritis, but it's a real problem. And I think we underutilize these 18 to 22 pound below the knee Jobst-like stockings. Jennifer.
Yeah, I agree. I mean, I think support stockings are great, and you've emphasized the major problem is most people cannot get them on. And so that's a real problem, particularly if you have arthritis of your hands. You have
Right.
arthritis, you're not going to be able to pull them up. So sometimes we'll go with not quite so much compression. I'll encourage them to get something that they can get
Put
on. Or we've even had people ACE wrap their legs,
Right.
which is easier for some people.
Yeah, and that's what I do. If they can't do it, you start with the ACE wrap. And the problem is also, if you start really fixing the edema in their legs, they'll start having leg cramps. So it's sort of like, and then they'll refuse it completely. So
Right.
it's sort of like that same story that you were saying, Chris, earlier. You got to start really slow, gradually build up to get
A few
into.
minutes a day, a few hours a day, and then gradually kind of get used to wearing them.
Yeah, but they're wonderful. And people who have bad veins, it's only going to get worse. You really need the support hose. I had one patient, I begged her, I pleaded, I pushed. Finally, she got into wearing them. And she came in one time, like 3 months after, finally she got into wearing them, and she said, "Darn you, Dr. Holm, why didn't you push those? They really make a difference. Why didn't you tell me I had to wear them?" You can't win. So I think there's a lot of things that people can do. But you know, this putting on the hose, this 95-year-old man who is on, who, if he can do it, we can all do it, couldn't we? Mm-hmm. So I'd strongly encourage it. Now let's talk about pain medicines, because I think we all got a little burned with the non-steroidals, fearful that ibuprofen and those things can hurt the kidneys and can hurt the stomach, and therefore it's been moving in the direction of narcotics and Tylenol for people who have chronic pain. And since they started going, where are you on a 10 scale with pain, people are never 0. You know, and so our duty is to relieve all their pain, and it's pushed us to provide pain medicines, and there's been a dilemma with narcotic abuse, probably as a result. Chris, any comment?
I mean, that's the slippery slope, is we're chasing a 0. Somehow along this process, you know, I think the intent was, are we adequately asking about and addressing, do you have pain, or where is the pain? Now it's become, if you have any pain at all, we have to try to throw some kind of medicine or something at that to try to eliminate it, to try to make it a 0. And oftentimes, like you said, that doesn't happen. We can't eliminate it completely. More appropriately, what we should be thinking about is improving their function. How can we help you manage this problem or manage your pain so that you can get back to work, get back to exercise, get back to being with your family? That should be the priority, not we're chasing a 0 and trying to make you feel like you're 18 again.
Right, and of course you start pushing those pills and then they become less functional.
Well, we've added another problem to your problem list. You still have the knee arthritis, you still have pain, now you have
Dependency on narcotics.
and
Or you're
constipation
constipated,
and other issues.
Yeah.
Falling more.
Yeah, no energy, or you usually just feel worse and you're still in pain, which isn't really
Not a good thing.
no.
So the whole world is pushing it now against it. I mean, Marty Jackley in the state of South Dakota is really trying to battle the over-prescribing on our part and the overuse, because much of it is diverted. It's not taken by the patient. It's sold to somebody else on the street, and we're seeing a lot of that. Any numbers? Do we know any numbers about how that is happening?
I think it depends on the community. I think certainly meds are shared. Meds are not kept safe in a home. A lot of people have old prescriptions that they haven't disposed of. There's things sitting around, that kids or grandkids or others could get into. I mean, we could certainly improve how we handle or manage these medicines. They should be considered very dangerous, very specific medications for a specific purpose.
Right. I tell you what I did. We were cleaning our drawers and found 2 old prescriptions. One time that I had a bad abscess in the back of my throat, and that was like 5-year-old drugs, and then a 3-year-old drug from another thing that a doctor prescribed for me. And I thought to myself, family medical people, that's a danger. We're the highest risk for potential abuse, and it scared me. So I took them, put them in the coffee grounds, and threw them away.
And even more, what we're seeing now is a lot of our sheriff's offices, a lot of our law enforcement offices, even some pharmacies have take-back programs where there's receptacles, there's places where they will, collect.
Dispose of them safely.
Yeah, used or unused medications.
Yeah.
Some of that is a problem with the providers and the prescribers. I think we're probably giving people too large amount of prescriptions or too many number of pills.
Right.
You have a surgery, you have some kind of a treatment, you really need to think about, I'm going to get you through a week, 10 days, 14 days after your surgery. I don't need to give you 30 days worth of narcotic pills.
Yeah. So we need to push our doctors, although it's getting more and more difficult to even prescribe narcotics nowadays. But is that a problem?
Yes, I mean, I guess for me, I think every doctor thinks they don't prescribe very many,
Yeah.
right? And I probably prescribe more than I realize. I don't use a lot of long-acting narcotics. So in my situation, I might be giving you, say you have gout attack,
Yeah.
and I'm giving you, that really hurts, right?
Yeah.
And I'm going to give you some pain medicine, narcotic pain medicine, while I'm getting your gout attack under control, and I'm going to give you 7 days worth, for example. Or say you have degenerative arthritis and you're 78, 79 years old and you're on Coumadin and you can't take non-steroidal anti-inflammatories, and you say, I take 1 hydrocodone a day and that really helps me. I'm like, I'm okay with that. But is that, this is where it becomes a challenge, because now you're getting chronic pain medicine, but this person doesn't maybe have sort of the risk profile of, I'm 25 and have pain. Well, that's a lot of life to live to deal with being on a narcotic.
Yeah.
So every situation is going to be different. Like we talked a little bit earlier, the pendulum kind of went from everybody needs to have their pain treated to now nobody should be on any of these medicines, they're so dangerous. And there's a balance there where, yes, we want to be careful and want to pay attention, but sometimes it's okay for someone to take them in appropriate
And
doses.
that's that middle ground, right? The gray area is you have real pathology or problems. You've had trauma, you've had an injury, you've had a bad surgery outcome, you're going to have pain. How do you manage that? But that includes a lot of new steps and things, right? We're utilizing the state prescription drug monitoring program.
Right.
Agreements with that prescriber. If you're going to obtain medication, they're going to ask that you only go to one pharmacy, that you're only going to see one doctor. You're not going to get meds from your rheumatologist and your orthopedic surgeon and your dentist and your primary care doctor, that there's going to be one person
prescriber.
quarterbacking that.
Yeah.
They're going to have an agreement with lots of informed consent and understanding of this is what happens when you take these medications, and you're very informed as to those risks. And there's certain medications that I think as we learn more aren't going to be prescribed together. The days of, a Valium and a narcotic, or a sleeping pill and narcotics, mixing those things together are where we got into trouble, right? And people would go to sleep and not wake up. And there's a lot more regulation now as far as peeling that back and really trying to limit or not do that in those combinations.
And I think also what layers in here is our culture created an expectation. There's an unrealistic expectation that I should not have pain.
Right.
And that's something that we kind of have to be re-educated about. You know, if you fall and you break your arm, it's going to hurt. And I'm not supposed to make you pain-free,
Right.
right?
There's a reason for the pain.
So
It protects you.
So we have to recondition because we've been through pharma, whatever, sort of taught as a society that, oh, gee, nothing should hurt.
Yeah. Chasing
we
that
have-
zero.
So we have to kind of undo
Yeah.
that thinking, and that's going to take some time.
That's a very
Took a
important.
while to get here.
Did you get that? Did you catch that point? I mean, there it is. We really want that to take home. Let's jump now from pain medicines to home safety and falling. I do know that as people get older, they're a higher risk of falling. And when you have falling, a large percentage of those people will have head trauma and loss of ability to think. If they come to the emergency room, there's like, from falling, a 60% risk of a fracture. And then there's a lot of pain. So what can we do to prevent people from falling? I mean, what are the take-home messages on falling prevention?
Well, the three things that give us balance, or the three things that we have, are our inner ear, which you can't really change much with.
Right.
Our vision, or our ability to see our environment. We see any obstacles, we see what's out there. And then our proprioception, or our feet and our sensation. And a lot of people, as they get older, they
Lose their feet
they get
feeling.
numbness, they lose that sensation a little bit.
Diabetics in particular, yeah.
Absolutely, get a neuropathy or some sort of injury. But even then, if it's at nighttime, the lights are off, you don't have that ability to see your environment, now you're more at risk for, you've eliminated 2 out of the 3 variables, now you don't have that sense of balance or where neutral is, where level is.
Right.
You're way more susceptible to fall.
So what can you do in your environment? I mean, I know that occupational therapists will do a home safety eval. What's that all about, Jennifer?
Well, they usually come in, assess the home. For example, that maybe they recognize an area of risk in your home. Maybe you need grab bars in your bathroom. We get rid of area rugs. That's sort of a no-no. And put up night lights, up at night, so that if you get up in the middle of the night and have to go to the bathroom, there's lighting. Different areas where they see potential risk, and then we try to modify that with, like I said, braces or handrails and other, making
Right.
plenty of space that you have to move around, not having a overcrowded home and, things that could.
Cords that are in the way.
Yeah.
And I think we use appropriate, what we would call gait aids, a cane or a walker.
Right.
A lot of people don't particularly like that for vanity reasons, but absolutely at home, you're spending most of your time there. That's where you really need to be safe and stable, and if that's what it takes, not only something that is there that you're going to use, but also that is sized appropriately. The cane is the right height, the walker is the right height, it's in good function, the handbrakes work if it has brakes, those kind of things.
Yeah. I've often, the thing that always strikes me, and this was an aha to me, is that many times those things are really a third leg to tell you where you are in space. Not so much the cane that holds you up, but a cane that you can tap and you can say, oh, okay, there's the floor. Now I've got got one leg, 2 legs, and a cane telling me where I am in space. I mean, same deal. People feel their wall, they get the table, they get another chair, and they make their way to the bathroom. That cane can tell you where you are in space. And that's that same idea of walking. People who are outside walking, I like them to have walking sticks to tell them where they are in space. I mean, I've said it isn't necessarily, mostly you could do it with a yardstick. You just need to know where you are. That's what it's doing for you. Although it can do a double with a rubber end. And I slipped. It caught me. So I really think we should make it popular to have a cane more often. It used to be the dandy would have a cane, right? So. Well, home safety and gait aids. Anything more we want to talk about before we go on?
Well, I think we talked about getting stronger. That's where that also comes into play. If you slip and you have leg strength, or your hips and your back are strong enough, you can catch yourself, you can, you know, rewrite the ship, so to speak, and hold yourself up. If you're weak and your leg gives out and you try to catch yourself but your leg buckles, you don't have the strength there, that's when these falls happen. You need to be able to kind of have a little bit of that compensation or that reserve.
There's a group of German exerciser strengthening geriatric people, the Esslinger exercises, that's been encouraged. And they suggest, you know, you practice sitting down in a chair, standing up again, sitting down, standing up, or deep knee bends, not so deep that you hurt your knees, but enough to strengthen the hips, because that's the best brace, right? You have any thoughts about that?
Sounds fantastic. I think often we see some of our older patients that they struggle to get up and down out of a chair.
If we can practice on that one before we get unable to.
Absolutely. And in and out of the car, in the bathroom, those are very important muscles, those hips and legs and thighs.
Yeah, yep. So let's talk about other kinds of arthritis before we run out of time, Jennifer. I mean, we've talked about osteoarthritis. Let's just flip into the question of polymyalgia rheumatica. What is that?
Well, that's not an arthritis, really. That's more of like a pain syndrome that people can, over around 50, 55 years of age, where people will get proximal muscle pain, so pain in the shoulders and thighs. They may just feel bad, in fever, just malaise. And when we examine them, they're having a lot of pain. They're very uncomfortable. But we don't see joint swelling, warmth, redness. Everything works okay. They're just having a lot of pain. The classic is, for example, a woman she wouldn't be able to get their arms above their head to do their hair because it just hurts so much. And we'll see evidence of inflammation in their blood work, and it's
elevated SED rate.
Mm-hmm. And giving prednisone dramatically improves the process. This is like a hot knife through butter. Like the next day, these people, they're much better. And so it's a totally different mechanism of action or way in which it's not a chronic mechanical problem. Like osteoarthritis is really a structural problem. This is more of an inflammatory problem, or your immune system sort of creating a problem. We don't really know why that happens, but it's treatable and a little bit easier to treat.
So the take home is it's really treatable.
Very treatable.
And the clue would be trouble getting your hands over your heads or climbing stairs, or what would be the real clue?
Well, that, I think, just a lot of pain in the muscle as opposed to the joint. It's not so much my knee hurts or my shoulder hurts, but it's like the whole muscle between the joint is painful. And just kind of a sudden loss of function.
Okay.
Not gradual.
So we've got just a little time. Any take-home messages that you would like to give, Chris?
I think we've stressed function and we've stressed being active. I think that's, again, the most important thing that you can do is whether you're already in shape or whether you need to be in shape, start movement, start some sort of exercise and commit to that and try to be as active as you can. Try to maintain that natural plan that we have for ourselves.
Function. 20 seconds, any take-home message?
Yeah, I agree with Dr. Dietrich. Really, this is, being active, live well, eat well, be active. That's a good baseline. There are lots of different types of joint pain. Your problem may not be a simple problem, but there's a lot of really tangible things that you can do to have your symptoms well controlled.
Very good. Thank you very much. We'll be back right after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
If you don't use it, you'll lose it. I bet I've heard and repeated this age-old aphorism a million times or so, but can it be overused? The adage about using it certainly fits when trying to bring to wellness all sorts of medical systems. Working the brain with puzzles and conversation helps ward off memory loss. Walking fast enough to cause one to huff and puff keeps the heart and lungs strong. Regular sexual activity helps prevent impotence. Filling the gut with a high-fiber diet keeps the bowels in shape and makes you a regular sort of guy. But what can you do when it hurts to move those old joints? Should you rest or should you exercise a joint with degenerative arthritis? Experts say this depends on the state of that arthritis. If it's a hot and inflamed joint, it's better to address it first with expert advice, medication, and time, and to not force a lot of movement until later when it's cooled down. If, however, it's the cool yet stiff type of arthritis, then that's a different story. I always go back to one well-done study where they found a large number of older people with very bad osteoarthritic knees, that kind the orthopedic surgeons would call bone-on-bone. Scientists divided them into two groups. The first group was left to their sedentary habits, and the second group was pushed to regular walking, stretching, and moving on those worn-out knees. So who do you think did better? You guessed it. The exercise group seemed to be in less pain, were better able to stay mobile, and rated themselves happier in general than the control group. One physician friend advised me once that motion is the lotion for keeping those stiff joints moving. The American College of Rheumatology gives us the following recommendations. Though some of the joint changes of osteoarthritis are irreversible, most patients will not need joint replacement surgery. Symptoms of osteoarthritis can vary greatly among those affected. And finally, exercise should be an important part of what we do to decrease joint pain and increase function. So say it again to yourself every morning while looking at that person in that mirror. Use it or lose it. Well, a great big thank you to our guests, Drs. Chris Diedrich and Jennifer May, for helping us with tonight's show. Their voluntary giving of coming to this spot and making this show happen. Thank you very much, both of you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, thank you, and stay healthy out there, people.
Can't get enough of the Prairie Doc? Then visit our webpage and other online programming. You'll find extended interviews with guests and more information on important medical subjects. Visit prairiedoc.org or follow us on Facebook. The best way to stay healthy out there.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association.
Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision,
Aberdeen Asthma and Allergy, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, Regional Health, and Swiftel Communications.
and Lynn Productions.